What do you remember from yesterday's session? Any volunteers?
Assalamu alaikum, Dr. Kaval.
Walaikum assalam.
Can I try?
Yeah, you can.
Okay. First of all, the transcondylar, far-lateral transcondylar approach could be used for the lesions that are present at the level of the foramen magnum and the upper cervical spine.
Okay.
And then we can do the we give the incision from the mastoid process to the up to the transverse sinus, and then up slightly above, and then go it medially, and then from the midline it comes back to the C4 cervical spine, or up to C2, depending upon the lesion. Then after the giving the incision and making the muscle dissection, we will do the craniotomy, in which we do the removal of the bone up to the 1 centimeter of the foramen magnum as well. We will remove that part, and we will remove the condyle of that side, occipital condyle of that side, uh, 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 according to the one half or one third, depending upon the lesions. After that, we will identify. We will do the durotomy with the curvilinear incision, and then after arachnoid dissection, we will see over lesion. Thank you.
Okay, that was a brilliant, brilliant summarization of yesterday's session and even the session before yesterday. So kudos to you for remembering it so well and summarizing it so well as well. Moving on. The first question that I want to ask today is, how do you differentiate between a far lateral approach and a far lateral transcondylar approach? Would somebody like to volunteer? What would be the main difference? Are they same? Or are they different approaches? Or are they variants of the same approach? Any volunteers? No one? So what do you think? Is far lateral and transcondylar, they are same?
No.
Okay, what is the difference?
Uh, in transcondylar, we drill the condyles of the occipital bone,
And what do you think about the far lateral approach?
in which we go just before the anterior lateral, just sorry.
That's okay. Anyone else? I was wondering if you people thought about this yesterday while you were all attending the far lateral session. So let's start from the very beginning. What is transcondylar approach? Consider this as the heavy duty version of the suboccipital cranectomy. Like we have the suboccipital cranectomy, you all know it by heart. It's a very easy approach, not exactly easy, but relatively straightforward to do, relatively straightforward to understand, and straightforward to explain as well. Yes, Dr. Abdullah, there are same, basically far lateral transcondylar is a variant. Transcondylar is a variant surgical approach of the far lateral. I'm going to come to that later on. So this is a heavy duty version of the suboccipital cranectomy. Why? Because we are taking some portion of the foramen magnum. We are also taking out some portion of the condyle. So you are all with me so far? Let me change my
Yes.
slide. This is a comparison. What do we mean when we say this is a standard far lateral and this is a transcondylar, which is a variant? So, if we are doing a standard far lateral, what is our axis going to be? The axis is going to be posterolateral pathologies only, right? So, with a standard far lateral, you are not going to get access to the anterior portion of the brainstem or any clival pathologies. You are going to be restricted to the posterolateral pathologies, the premedullary cistern, and the pica. With a transcondylar approach, when we are drilling the condyle, which is the major bulk of the bone here, what is going to happen is We are going to remove the bone which is obstructing our view to the anterior portion of the brainstem. I'm going to show you the pictures ahead so that you would understand what I am saying. Let's assume there isn't much space on this slide to draw. Let me try. So I'm going to draw this, a very rough version. Okay, this here is the foramen magnum, right? What ends up happening is this portion here, let me change my color. This orange portion here is the condyle. Okay, when we are doing the standard far-lateral approach, we can approach till here, this portion, but this bone here is going to obstruct our view to the anterior pathologies. So when we end up drilling this portion, what it does is it removes the obstruction that is obstructing our vision. I'll show you in the future slides so that that aspect is clear as well. How is the bone removal different? The bone removal is what differentiates it mainly. Let me change this slide. We do a suboccipital cranectomy in the standard Farlateral approach, then we do a C1 laminectomy, and then we open the foramen magnum, right? This is the standard Farlateral. When we take out the posterior one-third to half of the occipital condyle, we change a standard Farlateral position to the standard Farlateral approach to the transcondylar approach. Exposure, as I already told, we are going to get access to the posterolateral and the lateral portion, be it the pathologies, be it the normal anatomy. So the lateral aspect of the medulla is going to be exposed. The lower cranial nerves are going to be exposed. Whereas with the transcondylar approach, we are going to have access to the ventral portion or the anterior portion of the brainstem. Dura is basically opened in the same manner. That is not an apt comparison. Where do we make the base of the dura? This is transverse sinus. This here is the sigmoid sinus. This is asterion and the junction of the transverse and sigmoid sinus. The dura is based on the sigmoid sinus here. So we make the flap and we make a C-shaped flap and it is flipped on the other side. The base is the sigmoid sinus. So what are the drilling limits? This stops at the posterior margin of the occipital condyle, whereas this extends into the condyle. So are we conceptually clear till here?
Yes, Dr. Kaval.
Please excuse my voice because I have sore throat and it's not letting me talk very fluently. So do you people want me to go through the surgical steps first, or let's discuss everything else and then come back to the surgical steps? Because this is cheat sheet basically. I think I'll skip all of these. So what are the indications? And Dr. Sana very aptly summarized the indications. Any ventral pathologies, especially foramen magnum meningiomas, which are localized to the lower part of the clivus. For them, this is a gold standard approach. Lower clivus lesions like chordomas, chondrosarcomas, etc. And we have the anterolateral brainstem. These are the typical indications. If the location of the pathology is here, then we have to proceed for a far-lateral transcondylar approach. So now if you see, when we go far lateral, if you follow this arrow, let me change, this is far lateral. If we follow this arrow, then where do we reach? We reach here, and what is this portion? These are the condyles. And what are condyles? Condyles are basically thickened portions of the margin of this foramen magnum. They are very thick and they obstruct our view. So we erase this portion. Hence, we get access here, right? You can see all the other approaches where we can access the brainstem. This is all the other approaches. We can use retrosigmoid, we can use transpetrosal, we can also use suboccipital, but let's not go there because we have a lot to discuss today. What are the common lesions? I already told you, ventral foramen magnum meningiomas. If there is a schwannoma of any of the lower cranial nerves, if there is a chondrosarcoma, chordomas, vertebral artery aneurysms. We have cavernomas, like the cavernoma we discussed yesterday. This is the skin incision. And I'm sure you all remember.
You said?
Please mute yourself. Okay, coming back, usually we use a hockey stick shaped incision, and that extends to C3, C4, depending on the level of the pathology. The question is, when do we include the transverse sinus and when do we exclude the transverse sinus? So, would any of you like to volunteer? When would we include the transverse sinus in our exposure? Anyone? No one? Am I audible?
Yes, Dr. Kaval.
You people are exceptionally quiet, and I think I've lost my screen. Give me a minute. So my slide is audible, right? Oh, so my slide is visible, right?
Yes, yes, it's visible.
Okay. So you people are exceptionally quiet. Uh, that's okay. We are going to address this question. So the incision is, it's standard modified hockey stick incision. What is the superior limit? Roughly 3 centimeters above the pinna, 2 centimeters medial to the mastoid process. Then we follow the superior knuckle line. You can come back here. You see we have started at the mastoid process. Then we are curving towards the medial portion. We are following the superior knuckle line here. And then we are coming downwards. Inferior extension extends to the level of C3 or C4. You all are with me so far? This is the easy bit.
Yes,
Okay.
clear.
Yes.
Now we come to the muscle layer dissection. Dr. Itzas did a really good job of summarizing the muscle dissection yesterday because the muscle layers are really, really important. So what ends up happening is there are 3 main muscle layers. What is the first layer? The first layer is depicted here. It's going to include the sternocleidomastoid muscle, and it's also going to include the splenius muscle. What are we going to do with these? We are going to retract them laterally. Where do they go? They go lateral. Sternocleidomastoid and splenius muscle go lateral. This is the first layer, layer 1. Then we move on to the layer 2. Now you see that sternocleidomastoid and splenius have been retracted laterally. Where do we come? We come to the layer 2. And what does layer 2 have? The layer 2 has semispinalis capitis. Why is this important? Because we are going to detach this muscle right from the origin of this muscle. This is attached to the occipital bone. We are going to detach it and leave a very small rim of the superior knuckle line, and this is going to get retracted inferiorly. Am I clear?
Yes.
So, what was the first layer? Let's do a very quick recap. What was the first
Sterno
layer?
Sternocleidomastoid.
And
Uh,
Venous capital.
yes.
splenius. That's right, splenius capitis and sternocleidomastoid. Where do they go? Where do they get
Laterally.
reflected? Laterally.
Laterally.
Lateral.
That was what, layer 1, right? This is layer 2, right? This is semispinalis capitis. Where does this go?
Inferiorly.
Inferiorly.
Inferiorly. So we detach it from the superior knuckle line and we reflect it downwards. This was layer 2. Let's move on to layer 3. What happens when we take away the layer 1 and layer 2? Let me change my slide. This is the layer 3, which was discussed very thoroughly yesterday. So I am expecting answers. What do you see here? What is this layer? This
Vago
is layer
accessory
3.
triangle.
Um, let's stick to suboccipital triangle.
Okay.
Why suboccipital triangle? Are we on the vagus nerve?
No,
Where
no.
are we, by the way?
In the muscles.
In the muscles. Vagoaccessory triangle was where? When we were approaching the medulla. We are not approaching the medulla. We have not even crossed the muscles yet. So, suboccipital triangle, what is it guarding? When does it come? We are already clear that the muscle grips were mainly divided in three layers. The first layer was dissected laterally, the second layer was dissected inferiorly. This is the third layer, and this shows there are these three muscles. If you see, there is a superior oblique muscle here, okay? And then we have the rectus capitis major, and then we have the rectus capitis, we have the inferior oblique. Okay, these are the three muscles. I'm going to mark them in different colors. Let me change the color. This muscle, this muscle, and this muscle, they are making a triangle which is called the suboccipital triangle. Why is this important? This is important because it helps us identify the vertebral artery. If you do not stop while you're dissecting and you're done dissecting the first two layers, if you do not stop here and take a look and see and that these are the three muscles and we need to stop and we need to assess the anatomy, then you're going to injure the vertebral artery inadvertently. Why? Because the suboccipital triangle is containing the vertebral artery, which is visible here. Let me clear all my drawings so that it's visible to you. Now, if you see, what are the contents of the suboccipital triangle? The contents are going to be vertebral artery, the vertebral venous plexus. I'm only going to write the short forms. Vertebral venous plexus, and after the vertebral venous plexus, there is going to be the suboccipital nerve. So these are the three contents. There is something else which is a very important structure, and that is also visible in here. Do you see this? Posterior atlanto-occipital membrane. What is this doing here? What was the function of PAL? Posterior atlanto-occipital membrane stabilizes the CVJ, right? And where we are at CVJ. But it attaches here and we need to incise this sharply if we want to access the vertebral artery. So you cannot access the vertebral artery, you cannot mobilize it if you are not incising the posterior atlanto-occipital membrane. Am I clear? Or do you people want me to go over it again?
It's clear.
It's clear. So layer 1, layer 2, layer 3. This is the suboccipital triangle. Let me see. Where did my screen go? I have no idea why my screen keeps shifting. My slide is visible to you all?
Yes, it's visible to us.
Okay, it's not visible to me for some reason. Just give me a minute. Mhm. Is it visible?
Yes, Dr. Kaval, it's visible.
I have no idea why I have lost it. It's not visible to me. Zoom is acting strange today. Let me reshare my screen. Give me a minute.
Okay.
Okay, I'm sorry for the interruption. Let's come back where we are. So we were in the suboccipital triangle and we were discussing its contents, and its contents included suboccipital nerve and vertebral artery and vertebral venous plexus. And we also saw the posterior atlanto-occipital membrane, which stabilizes the CVJ. And we learned that we have to incise this membrane here if we want to access the vertebral artery. This is the third layer. Now we move on to your question. I'm going to come back to the steps. I just want to give you a brief overview first. Don't worry if you feel lost. It's all going to make a lot of sense at the end of this presentation, inshallah ta'ala. So, would you include transverse sinus? There was a very simple answer to this question. If your lesion is high enough, you are going to include it. If the tumor is extending to the upper clivus or the CP angle, or if you want to expose the transverse sigmoid junction and you want to retract the dura superiorly, then you are going to expose the transverse sinus. And if you want the vascular control, you want access to the jugular bulb, then we must identify the sigmoid sinus to control, to have proximal control basically. So transverse sinus is included if the lesion is high enough or if we have the need for superior mobilization. This is a very good view of what bone is taken of the occiput and what bone is taken of the C1. You can see that this marks the C1 laminectomy, and this also marks the condylar region and the suboccipital cranectomy that needs to be taken down. This is an illustration after the cranectomy and after C1 laminectomy has been done. But there is a very important step that has not been done here, and what is that? What do you think is happening to the vertebral artery? Is it mobilized here or it is in its normal position?
It's in normal position.
It's in its normal position, that's right. So it hasn't been mobilized here. Usually, when we are doing a far lateral transcondylar approach, we need to mobilize it. How do we mobilize it? We are going to come to that part later on as well. And you see here the sigmoid sinus is visible, the jugular bulb is visible. And why is jugular bulb important? Because if you want proximal control of any hemorrhage or any emergency escalation, then we have the proximal control over here. You can see that C1 laminectomy has been done. Let me move on to the next slide. So, can you orient yourself? What is the superior aspect? What is the inferior aspect? Where's the surgeon standing? Any volunteers? I don't like you people so quiet. Anyone?
Yes, okay.
Okay, yeah. Assalamu alaikum, Dr. Hussain. I'm so happy to have you back.
Salam. No,
So,
thank you.
would you want to explain where the surgeon is standing? What is the superior portion? What is the inferior portion? What is going on in here in this image?
This is the upper border of the view is the tentorium, so it's the upper border of the field. The tonsil is laterally, and the right side the ICA in the field. So the surgeon,
The surgeon is standing on this side. You are right.
yes,
You're absolutely right. So,
yes.
you would have to tilt your phone or laptop, whatever screen you're using to watch this session slightly so that you get a better view. The surgeon is standing on the side of the retractor. What you see is a visualization of, you see the lower cranial nerves here. This is the cranial nerve 10. Just give me a minute. This is the cranial nerve 9. Here, this is the cranial nerve 10. This is the vestibulocochlear nerve. If we go slightly deeper anteriorly, we are going to find the facial nerve as well. You see the 11th nerve, the spinal accessory nerve, and you see the hypoglossal nerve here as well. So what ends up happening is we are retracting the cerebellum. Ideally, when we are doing transcondylar, retraction should be very minimal, and that is why we use the park bench or the lateral position. So the cerebellum gets retracted due to the gravity, right? So we are retracting and we are looking at the lateral view. We are not at the anteromedial view as of now in this dissection. But once we open the dura and once we are through the arachnoidal dissection, this is the first view that you're going to see. Let me change my slide. Are you people with me or lost? Apparently, you people are not. You would not want to respond whether you people are here or lost. What's going
No,
on,
it's okay,
guys?
but
This is an interactive session and it's not going to be a lot of fun. So these are
I
the structures. These are the
I think some
structures.
of us are fasting, so it's
Yeah, Dr. Sen.
yeah, okay.
Okay, so these are the structures which are at risk. They were discussed at length by Dr. Itzaz yesterday. The vertebral artery is at risk, understandably so. The lower cranial nerves are at risk. Hypoglossal nerve is obviously included. Why are we counting it separately? Because it travels through a separate canal. Since it travels through a separate canal, this becomes an independent consideration. And then we have the sigmoid or the jugular bulbs. Please mute yourself. So we have the sigmoid and the jugular bulbs as well. And this is basically an overview of what structures are at risk. Moving on, how do we mobilize the vertebral artery? Probably the heart and soul of today's session. How do we move? Identify the triangle. What was the triangle? The suboccipital triangle, bounded by rectus capitis posterior major and the superior and inferior oblique muscles. I'll go back to that image so that it you end up remembering. What was this? This was the superior oblique muscle. This was the inferior oblique muscle, and this was rectus capitis major, rectus capitis posterior major. I keep mixing these names. So this was the suboccipital triangle. This was the posterior atlanto-occipital membrane here. This here was the vertebral artery. Vertebral venous plexus is not visible. So this was a refresher. Moving on to the same slide. We have identified the vertebral artery. And what do? We palpate it, feeling the pulse, or we are going to use a microdoppler probe to confirm the pulse of the V3 segment as it loops over the posterior arch of C1. How do we manage the venous plexus bleed? We manage it just like we manage the venous bleed anywhere else in the brain. Low bipolar cautery, we are going to use irrigation, gentle pressure, hemostatic agents. We are going to avoid using excessive bipolar cautery because it's going to damage the vertebral artery. This is an illustration so that you people end up remembering. What do you see here? What do you see here? This is a label diagram. This is rectus capitis posterior major. And what is this? Obliquus capitis inferior. This is
Inferior
obliquus
oblique.
capitis superior. Yeah. Basically, they are the same names. Some of them are in Latin, some of them are in modern English. What do we have here? We have suboccipital nerve as the content, we have the vertebral artery as the content, and there's another thing which was the venous plexus. So if somebody ends up asking you the contents of the suboccipital triangle, there are three: vertebral artery, vertebral venous plexus, and the suboccipital nerve. And the triangle is used to identify the vertebral artery before its mobilization. How do we dissect it? We use the same dissection technique that we use while we are taking the periosteal flap. I am sure all of you have harvested the periosteal flap from the skull, right? So you know that we gently retract the periosteum and we dissect subperiosteally. That is the same technique we use to dissect the vertebral artery of the arch of the C1. So this, let me draw the C1 arch. So this one here is the arch of the C1. Please excuse my poor drawing. This is C1. This is the spinous
Uh,
process of the C1. This is
I
the...
have one comment. Excuse
Okay,
me,
yes, Dr. Sen.
about the step of mobilization of the vertebral artery.
Okay,
Some of us found that when we use forceps and sharp dissection away from the vertebral artery,
okay.
it's maybe better than we use it as we harvesting periosteum. You mean blunt dissection?
Oh, yes.
I'm getting you right.
Yeah, that's right.
I'm getting you correct. You mean a blunt dissection with
Yeah, I was not commenting on the type of dissection. I was commenting on the structure in terms of periosteum. Because when I'm saying that we are going to go subperiosteally, that means we are going to slightly pull the periosteum up and we're going to go under it. There's a very small plane a very fine plane between the periosteum and the bone. We need to find that plane. We need to go in between that plane and separate the vertebral artery gently, very gently. Obviously, we cannot do the blunt dissection here. Then, what do? We release the ligament. Which ligament? Posterior atlanto-occipital membrane that I showed all of you. There are a few pictures here in the session as well. What does it do? It was holding it in place. We are going to dissect it very sharply, gently but sharply, and the artery is going to get free from the C1 arch, and then we mobilize it using a small dissector. Gently peel the artery. Obviously, we are talking about the vertebral artery, so all the work is going to be very gentle. We are going to peel it away. Where are we going to peel it away? The direction is very important, inferiorly and medially, away from the C1 sulcus. Why? Because the surgical field is lateral. So we are going to mobilize it away from the surgical field and away from any harm, inshallah. So if you see this image, you can see this is the posterior atlanto-occipital membrane here, which is hooking the vertebral artery onto the arch of the C1. And when we incise this sharply, this area gets free and the vertebral artery is free to be mobilized. Am I clear till this?
Yes.
So, if you see, this is where it's getting mobilized. They are mobilizing it medially towards the midline and inferiorly because this portion, this is the surgical field. Here is the surgical field, so we are mobilizing it away. What was the other most important structure that was at risk? That was hypoglossal nerve. Why? Because I mentioned that it does not travel with the other lower cranial nerves. It travels in its own canal, which was the hypoglossal canal. Now, why is that important? Hypoglossal canal is it has a very peculiar direction. It runs posterolateral to an anteromedial direction, which is going to mean that if this is foramen magnum, and if let me draw, if this is occipital condyle here, and imagine that this is the occipital bone. So what is the direction going to be? Posterolateral, anteromedial. The direction is going to be like this. We are starting from a posterolateral side, we are going to the anteromedial side. There is an illustration ahead. I'm going to show you that. What is the superior boundary? The jugular tubercle. The inferior boundary, occipital condyle. If you remember this, perfect. If you don't, do not fret. I'm going to upload a PDF which is going to review all the approach. And the location is roughly at the junction of the anterior 1/3 and the posterior 2/3 of the condyle. So now do you get the direction that I was talking? This is the hypoglossal canal. It's going from posterolateral to anteromedial. And this is a coronal section. What is this showing? This is showing the close approximation of the vertebral artery, the condyle, and the hypoglossal nerve. So this is the vertebral artery, this is the occipital condyle, and this is the hypoglossal nerve here. So when we are drilling here, and this thing we have mobilized it downwards already, as we discussed. So the vertebral artery is lying below. It's here. Imagine that it's not here in this picture. Vertebral artery is safe, far away from any harm. But we are drilling in the condyle. And when we are drilling in the condyle, what is close? The hypoglossal nerve in the hypoglossal canal. So we have to take care of not injuring it. How do we do that? Well, there are certain mechanisms that we can use. The best one, use intra-op EMG. It saves you from a lot of headache. If you have that in your setup, you're very fortunate. There are going to be some needle electrodes that you would place, or the electrophysiologist will place on the lateral border of the tongue. If there are burst activities, the nerve is irritated. If there is strain activity, it is under sustained stress. And we have to use triggering. For the triggering, a monopolar stimulator is used. But if you are a safe surgeon, just using EMG is not going to protect your patient's hypoglossal nerve from you. Why? Because the way you are going to drill the occipital condyle is really, really important. What is the technique? The technique is summarized here. If you see, there is an inside out rule. What do we mean by inside out rule? We drill the posterior and the superior portions first, and as we go deeper, we notice that the bone becomes thinner, slightly papery, easy to take out, and when that happens, we know that we are near the hypoglossal canal, right? When that happens, we switch to a diamond burr. Why? Because this is more accurate, it's finer, and even if we end up breaching the bone, it's less likely to tear the nerve sheath. What is the gold standard thing to do? Use a lot of irrigation. Constant irrigation is mandatory if you do not want the hypoglossal nerve to get thermal injury from the burr, because the drill and the burr, they generate a lot of heat, and there can be secondary injury even if you have not done any physical damage to the hypoglossal nerve. Are we clear till this? Folks, are we clear?
Yes.
Okay. This is just a summary of everything that we have discussed so far. You can see the ventral ramus of the C2. You can see the ganglion of the C2. What do we do with this? We retract it gently, inferiorly, with the help of a nerve hook. We see the transverse process of the C1. Why am I marking this? Because this person in their dissection has also taken out the foramen transversarium. Usually we don't do that. Usually we restrict ourselves to the lamina, but sometimes if you think you cannot mobilize the vertebral arteries sufficiently and adequately without drilling the foramen transversarium, then we have to take out the foramen transversarium as well. And then you see, this is vertebral artery. This was the remnant of the lamina here. If let me take this out. Just a minute. So do you see this thin strip of bone? This is where the lamina was under my highlighter. And then you have the vertebral artery. And then the dura is visible. The sigmoid sinus is visible on this side. That's it on this slide. Let me move on. So this is a very important question. Does transcondylar approach need a post-op fixation? I'm not going to answer this. You people are going to answer this, and we are going to come back to this after we are done with these steps, because I'm going to go back to the cheat sheet now that made me 5 minutes late. So what do you think? You have done a transcondylar approach in a foramen magnum, in an anterior foramen magnum meningioma patient. Are you going to fix or you're not going to fix?
Fixation करनी पड़ेगी.
Okay, Dr. Sana is going to do a fixation. Anyone else has an opinion? You can write in the chat box. Okay, so you don't want to write in the chat box? We have a few answers. Depends on the condylar removal. That's a very, very intelligent answer. Excuse me. That's the most apt answer. It's okay. Dr. Yusra is going to do a fixation. So if you are sitting in a formal setting, if you are sitting in an exam, or if you are counseling your patient before the surgery, always give the answer Dr. Abdullah has given. It depends on the condylar removal. If para-operatively you end up removing a certain amount of condyle, how much we are going to see, then we have to do fixation. If we don't end up removing that level of condyle, then we don't do a fixation, we let it be. We are going to come back to this slide at the end. Let me go back now. Let's go back to the cheat sheet, which is a lot of text, but it's going to make it very easy for you. This is spoon feeding, basically. What's the first thing to do? You're going to establish, we are starting from the beginning. When we are discussing surgical steps, we start from the beginning. What's the first prerequisite? Establish neuromonitoring, SSEP, MEP, lower cranial nerves, 11 through 9 through 12. We are clear? You're all with me so far? Patient position was very easy. We all knew It was discussed yesterday. It was also discussed today. Park bench, lateral decubitus with head flexed, rotated away from the lesion. Why are we doing it in lateral decubitus position? Because we want to use gravity as our major retraction so that the cerebellum falls towards the floor and we get a very good access on the sideline. The vertex is going to be tilted. Why is that? Because we want to open the surgical corridor. The top shoulder is also going to be taped downwards. The incision was easy. Make a hockey stick incision from the inion to the C3, C4 level. We clear this. We incise the skin, then we incise the superficial fascia, and we expose the first muscle layer. What was the first muscle layer? You all remember by this point, right? Sternocleidomastoid and splenioscapitis. This was the first layer. Somebody was asking in the chat box as well to repeat the muscle layers. I am repeating them here. Sternocleidomastoid and splenioscapitis, where do they go? They go laterally and inferiorly. Layer 1 goes lateral and inferior. This is layer 1. Then we have the layer 2. The layer 2 is semispinal scapitis, which is a bulky muscle. What are we going to do? We are going to detach it from the knuckle line and we have to reflect it inferiorly, medially and inferiorly. What's the third layer? This was the second layer, by the way. The first layer goes lateral and inferior. The second layer goes medial and inferior, which is semispinal scapitis. And then we have the third layer, which was the suboccipital triangle. Rectus capitis, posterior major, we have superior oblique, and we have the inferior oblique. What was the purpose of the suboccipital triangle? To identify the vertebral artery. So once we have incised the semispinal scapitis and we have retracted it medially and inferiorly, we come on the suboccipital triangle and we stop. Why do we stop? We figure out where the vertebral artery is. You are all with me so far?
Yes.
Okay. What are we going to localize? We are going to localize the V3 segment, which was situated on the arch of the C1. This loops over the posterior arch. We have to mobilize it and we locate it, then we do a suboccipital craniotomy from the midline to the posterior margin of the sigmoid sinus. I already made a point whether to include the transverse sinus in your craniotomy or not, and whether you want to do a craniotomy or a craniotomy. These are surgeon factors. Then we remove the posterior arch, we do a laminectomy. After we have done a laminectomy, we take out the posterior atlanto-occipital membrane as well to release the vertebral artery. Okay, moving on. We have mobilized the vertebral artery. Where was it going? If you all remember the picture, it was going inferiorly and medially. Why? Because the surgical field was here, laterally placed. So when the surgical field is laterally placed, we are automatically assuming that vertebral artery gets mobilized inferiorly using subperiosteal dissection. Then we very gently retract the C2 ganglion using a nerve hook, where inferiorly. So most of the things are going to go inferiorly. The semispinal scapitis, the vertebral artery, the C2 ganglion, all of them are going to go inferiorly. What do we do then? Then we drill the posterior third to half of the occipital condyle using a diamond burr with irrigation. Why a diamond burr? Because it is finer. It's not going to tear the nerve sheath even if we end up puncturing the bone. When do we stop drilling? Once we see a bluish halo, a bluish shadow, which is the visualization of venous plexus within the hypoglossal canal, we stop drilling. Why? Because we want to protect our hypoglossal nerve. Now, what do? We come back, open the dura, and let me see, turn on my pointer. We open the dura, middle to the sigmoid sinus, and then we make the flap based on the sigmoid sinus here. And how do we retract the vertebral artery? We leave a protective dural cuff around the vertebral artery so that it can be mobilized, because if you don't leave a cuff, and you try retracting or you try mobilizing it much, it's going to kink the vessel and the patient is not going to have a very good outcome. So you have opened up the dura, you have mobilized the sinuses. Sometimes we might need to mobilize the junction of, just give me a minute. I'm so sorry for the interruption. So we are at the dura, we made a flap, and then we are back to the arachnoid. We discussed yesterday how do we open the arachnoid. We use a very fine needle to open it up sharply, very gently, or we use micro scissors. Once we do, opening the arachnoid is an art. It's a beautiful, beautiful art, probably the best portion of the microsurgery. So we open the arachnoid of the cisterna magna, we drain the CSF. Why do we do that? Because we want to relax the brain. And then we identify and preserve the lower cranial nerves and the pica. I have shown all these images which were relevant so that I could just briefly review the steps. What do? We resect the lesion between the corridor, and there's a specific closure technique as well. So, what are we going to do? Assuming that we have resected all the lesion, now we seal all the exposed mastoideo cells. How do we seal it? We seal it with bone wax. We perform a watertight dural closure. How do we do that? We make the anesthetist do the Valsalva maneuver. We close it primarily if that is possible. If primary closure is not possible, then we are going to use a dural flap, a prosthetic dura, whatever works for you in your particular institution. And then the void that we created due to drilling of the condyle, we are going to fill it with fat or muscle to eliminate the dead space. And then we have to reapproximate the suboccipital muscles over the vertebral artery. You have to cushion the vertebral artery if you want to save it from any further damage. Let me move to the next slide. This is the interesting bit. You have to remember that you cannot leave semispinal scapitis as it is. If you left a thin line of the knuckle, if you left a thin knuckle line, you're going to reattach it with sutures. If you did not leave any thin rim with which you can attach this, then you are going to drill holes in the bone and then attach it, because this is a very important muscle in terms of maintaining the neck posture. Then we reapproximate the sternocleidomastoid, all the superficial muscles. How do we do that? Wherever we incise them, we take it back and then we resuture it. Then we perform a watertight closure of the necrophagia to prevent any pseudomeningocele. This is the summarized version of the transcondylar far-lateral approach. And let's very quickly go to the last slide. So, are we all clear?
Yes.
Yes.
I'm going to leave a
Yes,
PDF
thank you.
handout. I'm going to leave a PDF handout of all these steps and everything else on the WhatsApp group so that you people can always go back and check. Obviously, this is not a textbook. Always let me know if there is a mistake. I can go back and make a correction. So, does transcondylar approach need a post-op fixation? Dr. Abdullah said that depends on how much condyle we have taken. There's a 50% rule. If you have done more than 50% removal, you have to go for a fixation post-op. You can do it in the same setting, you can do it staged, but you have to fix it. If the condylar removal was less than 50%, then it is generally considered stable. You are only going to fill the condylar void with muscle or fat graft or anything else, and no fixation is required. So, what are the mandatory factors for fixation? If you compromised C1 lateral mass during the drilling, if there was ligamentous injury, Eller ligament was compromised, tall was compromised during your surgical exposure, that is a mandatory factor for the fixation. If there was any pre-existing instability, then you have to fix. So these are certain mandatory factors. Otherwise, the 50% rule stands. Less than 50%, you do not need fixation. More than 50%, you need a fixation. And that's a wrap. of a very, very difficult approach. I'm not sure about all of you, but I have always found this approach very difficult. So I'm glad I got to do this because it did help me a lot as well. Any questions, any feedback, you guys can always leave on the WhatsApp group. Since we are running late, I would not take any live questions today. Thank you so much, everyone. And that's a wrap.
Thank you.